everyone, I'm Dr. Vinisha, and today we are going to discuss MCQs for pediatric anesthesia in ENT, ophthalmology, dental procedures, and difficult airway. Let's begin with ENT procedures. Okay. The first question, paradoxical cyanosis is seen in which of the following conditions? Cleft palate, craniosynostosis, cystic fibrosis, or choanal atresia? The correct answer here is option D, that is choanal atresia. We'll come to the explanation of paradoxical cyanosis in the coming slides. Next question. Select the correct statement regarding the anomaly in choanal atresia. Failure of the nasal cavity to connect with the aerodigestive tract, chronic inflammation of the paranasal mucosa, failure of the oral cavity to connect with the aerodigestive tract, or there is palatal hypertrophy and obstruction of the pharynx. So the basic pathology in choanal atresia is failure of the nasal cavity to connect with the aerodigestive tract. Which of the following is not an option for management of choanal atresia? A. Mitomycin C, B. Myringotomy, C. Endoscopic resection with stenting, or D. McGovern nipple or an airway. The correct answer here is B, that is myringotomy. Next question. Which of the following statements about choanal atresia is false? Bilateral cases present with respiratory distress at birth. Intubation with oral RAE tube provides adequate surgical access. Unilateral atresia is less common than bilateral, or it can be associated with Chart syndrome. The option which is false is C, that is unilateral atresia is less common. Unilateral cases are far more common as compared to bilateral ones. So now let's see a little bit about choanal atresia, what exactly it is. Basically, there's failure of the nasal cavity to connect with the aerodigestive tract, and it occurs in about 1 in 5,000 to 8,000 live births. It is more commonly seen in female infants. Now, there are various types, okay? It can either be complete or incomplete. It can be bilateral or unilateral. Now, unilateral choanal atresia, as we saw in the previous question, it is far more common than the bilateral one. And about 70% of the cases are usually unilateral. Bilateral ones are very serious, they have major clinical implications. And the bilateral ones are the ones which are usually associated with syndromes, such as your Chart syndrome or Pouzon syndrome. Now, what happens in neonates is basically they're obligate nasal breathers. We've seen that in the physiology. So if there is choanal atresia and if it is bilateral, then it leads to severe respiratory distress at birth, and you need to immediately intervene and to be able to establish an airway. Typically, the child will present with airway obstruction, stridor, and paradoxical cyanosis. Now, what is this paradoxical cyanosis? So the newborn turns pink when they start crying, in fact, because that is when they open their mouth when they are crying. So breathing becomes more efficient in cases of choanal atresia. That is why it's known as paradoxical cyanosis. The newborn turns pink when they begin to cry. Now, neonates who have bilateral diseases, you can, as soon as they are born, you will also see there is inability to pass the nasal catheter through the nasal cavity. And you can do a CT scan or a nasal endoscopy to confirm the diagnosis. Now, management options, they include you have to try and keep the mouth open to facilitate breathing. So you can use the McGovern nipple or oral airway, which can be strapped and kept in place till they begin to breathe orally. In very severe cases, even emergency tracheostomy and intubation can be needed when they present with respiratory distress. And if with all this, gradually the neonate can adapt to oral breathing, then the surgery can be delayed till the infant becomes about 10 weeks of age. Surgical intervention, what they do in that is either it's a transnasal puncture or a transpalatal resection, and endoscopic resection is also done with or without stenting, which can be inserted. Mitomycin C is used in treatment because it's an anti-proliferative agent. So because of that, it inhibits fibroblast proliferation, and it sometimes is applied as an adjuvant, after stenting also, to reduce the scarring and prevent restenosis, which occurs after surgery. Now, unilateral cases, patients who have just unilateral atresia, they usually do well, okay, post-operatively, and they don't require any special monitoring. But the patients who have bilateral repair that is done, then they have post-op course is also complicated, and they should be monitored in the ICU or HDU unit. Okay. Now, next question regarding tonsils. Indication for tonsil and adenoid resection include all of the following except obstructive sleep apnea, recurrent tonsillitis, enlarged adenoids, and complete cleft palate. Now, recurrent tonsillitis obviously is an indication, but in kids, the other indications include like obstructive sleep apnea and enlarged adenoids also. The correct answer here is complete cleft palate, that is option D. So, whenever there's like recurrent pharyngotonsillitis, hemorrhagic tonsillitis, enlarged adenoids, um, even in patients who have nocturnal upper airway obstruction and sleep disordered breathing, that is obstructive sleep apnea, recurrent otitis media, in these cases, tonsil and adenoid resection is performed. In cases of complete cleft palate, you will avoid removing the adenoids because the adenoids actually fill the velopharyngeal gap, which facilitates speech, which is otherwise not possible in cases of complete cleft palate. Next question. A 6-year-old girl is posted for adenotonsillectomy. History is suggestive of recurrent otitis media, snoring, mouth breathing, and occasional epistaxis. Which of the following investigations is a must in this patient? Polysomnography, 2D echo, coagulation profile, or renal function test? The correct answer here is C, that is coagulation profile. So, polysomnography is helpful in OSA patients, especially if they have hypertrophied adenoids, but it's not routinely done for diagnosis. You can also do a nocturnal pulse oximetry, which will give you the respiratory status. Now, you can see the patient is giving a history of occasional epistaxis. So, whenever any patient has history of epistaxis or easy bruising, bleeding gums, then it points to an abnormality in coagulation. So, you have to do a coagulation profile in these cases. They could have any underlying hematological abnormalities, like they could have sickle cell disease, von Willebrand's disease, hemophilia A. All these can be present, and then if it is present, then you have to optimize it preoperatively with transfusion of blood or the specific factor as per the disease. Other investigations in tonsillectomy include CBC, bleeding time, and clotting time, which have to be done. Next question. Which of the following is true regarding anesthetic management of adenotonsillectomy? Intubation with nasal RAE tube. Dexamethasone is contraindicated due to recurrent infection. Child should be nursed in propped up position in recovery, or pharyngeal packing should be done. The correct answer here is pharyngeal packing is a must in cases of adenotonsillectomy. So let's see a little bit about the intraoperative management of adenotonsillectomy. So you have standard monitors which you will put. The most important thing you will monitor is the airway pressures, okay? Especially when they put the mouth gag and it's a shared airway, so there can be kinking and airway pressures can rise because of that. Anti-silogox can be used to decrease your secretions. You can give glycopyrrolate for that. Now, dexamethasone, as you can see in option D, has an anti-inflammatory as well as an antiemetic effect. So it can be used in patients with undergoing tonsillectomy. Preformed oral RA tubes are the ones that are put for these patients, or you can also use a regular ET tube, but in that you'll have to keep changing the side depending on the side of the tonsil that they are doing. Nasal tube you cannot put when they have adenoids. Okay. Then pharyngeal packing, like your throat pack has to be done, so that will avoid the risk of aspiration. And after the surgery is done, you have to do a chexcopy, confirm the hemostasis, and you make sure to remove the pharyngeal pack and see if the pack is also soaked with blood on it. Pain management, usually it can be managed with just paracetamol, like either oral or IV, and you can use opioids, but judicious use is required because some of these patients also have OSAs. Now, NSAIDs in recent studies has not found to increase the risk of post-operative bleeding, but earlier studies used to say they cause post-operative bleeding and it was avoided by them. Now, child should be nursed in propped up position. Recovery is wrong because you have to shift the child in lateral and head down position, because if there is any bleeding, it will collect into the oropharynx and not go downwards. Okay. Okay. Which of the following is not used in assessment of a child with obstructive sleep apnea? Okay. Apnea hypoapnea index,